Awesome. Welcome to Coffee and Cases on the 17th of July. Today we have a really cool presentation and conversation really with Judy Sheehan, who's going to be sharing some experiences from her PhD as well as from her recent publication and also just some life experiences and some chat. Really love if you would be keen to get involved and to ask questions, think about things a little bit deeply and maybe think about how you interact and work in the world, how you identify yourself, what are the things that are specific to you that sort of change and shape as your work and your life changes and shapes itself. Just a quick reminder that this is a really safe space. The idea is to create really good conversation and to share some ideas, experiences, and thoughts. Today's presentation is sponsored by Stat Medical. It'd be really cool if you went and had a look at their website, if there's anything that you might be looking for emergency medicine equipment-wise. I'm not sure if Stan is on today. Stan, if you are here, you are welcome to jump in with a chat. I don't think that he is here today. Cool, I don't think he's here. So let's get straight into the chat. Judy, okay, are you able to unmute?
No. Yes,
Yay.
I am.
Awesome.
Can everyone hear me?
Yes.
Okay. Hello,
So
thank you for having me.
No worries. Thank you for joining us. I wanted to maybe start out with you telling us a little bit about yourself and where this paper that you published sort of came from, what experiences kind of led to the experience of creating the PhD work that you are working through, and maybe just like an intro so that everyone's on the same page as who you are.
Okay, I can start with that. I'm sorry if anyone is expecting a presentation. I didn't do a presentation. You're just going to get to listen to my voice for the next hour or so. So who am I and where do I come from? So my name's Judy. I have been in the EMS space for coming up to 20 years. And it seems really odd when I say that. That feels like a very long time. I started in 2006. I came up through the ranks starting as a BAA, went through all of the tiers up to an emergency care practitioner. And I worked in road operations in Cape Town, in Johannesburg. I've worked HEMS, emergency departments, little bits of everywhere in the clinical space. And then in 2013, I went into education on a more permanent basis. For the first couple of years, it was kind of a full-time in education, but still with one foot in the clinical space, which was really awesome. And then from about 2017, I've been exclusively in the education and academic space. What am I doing at the moment? I currently work at a university in Australia where I teach in postgraduate paramedicine. Where does my interest in the research that I'm doing come from? So I am a qualitative researcher, and for those of you that don't know much about research, there's mainly two main streams of research: qualitative research and quantitative research. So quantitative research is about numbers and measurements, it's experiments and statistics, which is not where my interest lies. So my interest is in qualitative research, which is about words and meaning, and it explores how and why people think and feel and behave in a certain way. So I do research by doing interviews and chatting to groups of people and observing things. So I really want to try and understand people's stories and their perspective. So that is qualitative research. So that is what I'm doing in my PhD. And it really came from the experience that I had when I left the clinical space and went more into the education and academic space. It was at times a very uncomfortable experience where you're kind of dumped into this area where you have not been trained to do anything in that space. At the time that I entered into education, I had my ECP qualification. So I was very well qualified to treat patients, but I had zero qualifications in how to teach people. And at the time, that didn't really occur to me. And the assumption was just that, oh, well, you've been working as a clinician for coming up to what, 8 to 10 years. So of course, you are going to be a great teacher. You've been treating patients for all these years. But those are two very different sets of skills and knowledge and things that you require. So the research that I'm doing is looking at that experience. So when you transition from one part in your career to another part in your career, and people could have similar experiences if you go from being in clinical and you're going into management, or you go from a student to being a graduate. So don't feel like the stuff that we're going to chat about today might not be relevant to you. We all go through transitions in various stages of our lives. So a lot of the stuff I think could be transferable in many aspects of career transitions specifically.
Awesome. Thanks for that sort of quick summary. So I have a few questions that I just kind of want to ask, and I think really the idea is to create a bit of a conversation. So if at any point there's anyone who has a question or something that they think they might want to share or experience, or maybe share an experience, that would also be really awesome. So just pop hands up as soon as you think of something that might be worth sharing or experiencing. Judy, I wanted to maybe start out with, we ended up teaching together for a little while, and we had these conversations back and forth over and over again in those first few years of our teaching experience. And you sort of touched on it now by saying that when you're in a clinical space and you become relatively comfortable with the content and the decision making and all the things that you might need to be able to do as an actual clinician, often the next sort of thought process is, well, then I can probably teach that stuff. And so that's kind of how both of us ended up in that teaching environment. How do we start to identify ourselves as specific titles / roles? How does that work in terms of the experience of the provider, but also the student? Are we academics? Are we educators? Are we clinicians who teach? How does it work? And what was the data that you found in your interview process and in your research process?
There's a lot. I mean, there's no one answer. There's no one answer to what all of those things are. I'm sure if you punch into Google or ChatGPT, it will give you a definition, but that definition is not really applicable just in every setting and in every sense of the word. So organizations will take a term and they will turn it into a title, and attached to that, they will put a job description, and with the job description comes responsibilities, and with the job description and the responsibilities comes the salary that goes with that. So you can understand that organizations need to have this to be able to slot someone in somewhere. They need to be able to put you into one of those boxes so that HR knows how much to pay you at the end of every month. But it causes a lot of confusion. So I've worked in 4 different countries, and across those 4 different countries, I've held the same, but also different titles. Mostly, I've been responsible for doing the same thing. But one of the big things that it caused for me, so in one place I was called a lecturer, and in another place I was called a senior lecturer. Now, just by adding the term senior to my role description, it puts a lot more pressure on you, because I'm a lecturer now. I'm becoming a senior lecturer. So my assumption is that there's going to be a lot more that's expected of me. What that expectation is another thing that is unclear, and the expectation of a lecturer in one country would be the same as the expectation of a senior lecturer in another country, or vice versa. So what I did find in this initial bit of research that I did do was that it is extremely inconsistent. It is inconsistent within institutions, so in the same institution, they will use different terms to refer to the same group of people. For example, they will call an academic and an educator and a lecturer will all be the same thing, but those all have different definitions. And then if we compare that across different institutions in the same country or different institutions across the world, it's all inconsistent. With the way that immigration works these days, there's a lot of people who leave their home country and go and work elsewhere. And you want that to kind of be transferable. And if we aren't able to agree on the terms that we're going to use to call people, then how can you expect someone to be confident in who they are? So that's kind of where the whole identity bit came in for me. It took me a long time to stop calling myself an ECP or stop calling myself a paramedic and start calling myself a lecturer or start calling myself any of the terms that is related to education, because I'd been a clinician for so many years and my training was to be a clinician. I was very confident in who I was as a clinician. But even though I was no longer working in that space, I had no confidence in in working in education. I thought I had, and I thought I was doing a pretty good job. But if someone asked me what I did, I immediately defaulted to say I'm an ECP. And if they then ask you, oh, okay, so where do you work? What do you do? Then you come with a whole roundabout explanation of, oh, well, I actually work, I teach paramedics. I don't work necessarily and treat patients anymore. And that's confusing. So it might seem like something trivial, like a title, but there's a lot of research that actually shows how much your title and your job description impacts how confident you are in what it is that you do. And a lot of people don't even realize this until you actually sit down and think about what does my title at work mean? For example, you could have two people who are both equally qualified. There's an ECP and an ECP. The one works on the response car and the other one is the base manager. They have the same qualification. So they might have different experiences, they might be different in age, they might be different in gender, or they might have other differences. But from a knowledge perspective, like formal knowledge perspective, they are equally qualified, but they have different titles. So what makes those two people different? It's the description of what they do, and that is based on their title. And based on their title, they are going to conduct themselves in a different way. So if you aren't able to identify with your title and in your job, then how can you really be confident in what it is that you are wanting to do? So the title is directly related to how confident you are and how you are then able to actually do your job. And that's not something that I'm made up. The evidence says that, and I have experienced that myself. So it does force us to be reflective. And when we teach students, we always say that you need to be a reflective practitioner, you need to reflect and you need to learn from your mistakes. But reflection is a lot more than that. So if you have never sat down and thought about what your job description or your job title more specifically means to you, then maybe it's a good time to just take a moment and actually really think about what it means to you.
Sure, there's so much in there. And I think so. There's one thing that I kind of wanted to catch on to, and that was this concept of confidence, because you've got the vocabulary to be able to explain yourself and to be able to describe who you are and what value you bring in not just society, but maybe in your family, in your workspace, in amongst other ECPs, amongst other educators. And this, it seems like such a silly thing. And I've sort of experienced the same thing, not only just in the workspace, but in a lot of sort of personal transition, is that if you don't have the words to describe yourself to somebody else, there's no relational interaction that you can build without the vocabulary. And it seems, like you said, so trivial, but it changes everything about your experience in that space. And so here we're speaking about the experience from the clinical to the higher education space, but the exact same interactions are happening when somebody transitions from clinical into business, from business into clinical. How do you find that vocabulary? How do you find those words that best describe who you are and what value you bring? Because as much as we don't want work to be the only value, it really is the first thing that anybody asks you. Who are you? What do you do?
Yeah.
So on the back of that, how do you now answer that question?
I'm very confident now in calling myself an academic. The job that I do is as an educator. I teach people how to be what in Australia is called a critical care paramedic. So that is my day-to-day job that I do. That's what earns me a salary. But working in higher education, there's more expectations than just being an educator. And that's often a misconception when people transition from the clinical space into education. And I'm sure there's misconceptions about transitioning from any one career path to another, where what you think you are getting yourself into versus what you are actually getting yourself into. So in higher education, there's the teaching bit, but then there's also the research and all the other avenues that generate money for specifically universities. Maybe not so much for your ambulance training college. They are also now higher education institutions, but they might not necessarily have those additional revenue incomes from publications and research and all of that. So I really enjoy that part of my job as well, although it makes up a really small percentage of what I do. So I am an educator. That's what I do in my day-to-day job. But if someone asks me what I do, then I say I am an academic. I wanted to just chat a little bit about what you mentioned about I forgot what you said, but what I wanted to say about that is something called imposter. It's not really syndrome because it's not a disease, but imposter phenomenon, probably a better way to describe it. And a lot of the time when you put into a new role and you have to take on new responsibilities, then people will say things like, oh, just fake it till you make it. And that is exactly what imposter phenomenon is. And if someone gives you that advice, that's terrible advice. You shouldn't have to fake it till you make it. We are all human, and cultural norms is often that if you change from one part to another part, you should immediately just know everything about that new avenue that you're going into. And that is an unrealistic expectation. And I think the culture in EMS especially is if you're moving up, or if you are just moving lateral, then under no circumstance should you say that you don't know what you are doing or you don't know what's expected of you. I'm sure there's some places where that culture shift is maybe getting a little bit better, but for the most part of my clinical career, you should never say if you don't know what you're doing. You pretend that you know what you're doing until either you get caught out or you just make it through without anyone ever knowing that you didn't actually know what you were doing. And that also has an impact on you as the person, because you feel like a fake, and it causes extreme amounts of stress because you are wondering every minute of the day, when are you going to get caught out? The transition from clinical to education. So I don't know if the saying still does the rounds, but there was a saying that used to go, those who can't do, teach. And that's actually really insulting, because being a clinician and being an educator or an academic or an instructor, those all have specific knowledge and skills that go with those. And you don't know why the person is making a career transition or changing their career direction. So it's not really nice to say things like that, because you don't know why the person has decided to change their career. And if you do make a career transition, yes, you might have to re-educate yourself. And that's something that's really important, is don't assume that because you've got knowledge in one aspect of the profession that it's automatically going to translate to another aspect of the profession. So there's a couple of things there. So it's the some culture changes that can continue to be improved. And then if you are going to make a career transition, make sure that you understand what you are getting yourself into. I think, Caleb, you can agree, when we went from clinical into education, we had no idea what we were getting ourselves into.
100%. So I actually want to come back to that, because we've spoken about transitions upward or sort of away from clinical, and something that I'm experiencing now in the last few years has been a transition away from education and back into clinical. And especially now, sort of with where I am in my career, is sort of a transition from more clinical and then sort of towards business, which is now for me a whole nother area that I realize I know nothing about and have a lot of work to do and to learn. So I've gone from a relatively okay practitioner to a teacher, which made me a better practitioner, to a clinician again, and then into the business space in the clinical environment. But I have sort of the imposter phenomenon in the other direction now, where I spend most of my time behind a computer working on concepts and thought processes. And now when I'm in front of a patient, now I feel anxious, because am I good enough? Have I worked hard enough? Do I know enough current information to be able to treat this patient to the best of my ability? And is somebody I'm working with maybe better equipped to manage this patient despite the years of experience, right? So it's this ongoing experience of shifting identities dependent on where you are at the time. And I don't think it's going to end, which means discomfort is going to follow forever.
Well, with discomfort comes change, and change can be good and change can also be bad. So there's some things that, I mean, I can only speak from my experience of the clinical to education change. So there's a couple of things that was really helpful in that transition, and then there were things that was really not helpful. And I suppose you can contribute to that as well, having gone through that shift specifically, but then also a couple of others. So you're entering into this environment where you are, number one, you are not trained formally to be an educator or an academic. No one, the first time I stood up in front of a class, I had never been taught how to do a PowerPoint presentation. Besides the fact that even when we were doing PowerPoint presentations was a very low quality method of teaching. But we didn't know that, because I was taught many times by PowerPoint presentation. So I figured, well, okay, well, this should be okay to do. But I was taught how to do clinical skills and how to do simulation and how to know which medication to give to a patient and how to do patient assessment. So sure, I'm assuming I can teach someone else how to do that, but I had no idea that things like educational theories and educational principles and teaching and learning and assessment design, all of those things, it's a whole new language that we had to learn. But in those first couple of years, and it was years that it took before we realized that, hang on, we probably need to learn a couple of extra things here. We just kind of went by what we thought was going to be the best option. And I'm probably not going to be very popular for saying this, but it still kind of baffles me that you can go and work at a university and teach people to be clinicians. And this is not unique to EMS and to paramedicine. This is still happening in many health professions, health profession domains, where if you want to go and teach people how to be a paramedic, all you need to do is be a paramedic. There's no formal requirement to have higher education qualifications. It is recommended, but it's not a requirement. So that brings me on to the next thing. Probably the most transformative thing in my in my professional transition was actually obtaining formal education in how to teach people. So doing a postgraduate diploma, doing a master's degree, whatever you want to do, but actually being formally educated the same way that I did my BAA and my NDIP and my ECP qualifications, actually going and being formally taught how to teach people. That was probably the most transformative thing for me, because then I had the confidence to participate in the conversation. I didn't have to pretend that I know what I was doing, because then I actually did know what I was doing. So that was really helpful. And then being surrounded by people who is going through the same, who's experiencing the same thing, and having a community of people where you can be honest and vulnerable and say, I have no idea what's going on. I have no idea what's expected of me, and not being judged for that. And I think that part we achieved really, really well when we all went through that early career educator academic phase at the same time. So that's really helpful. If you're in a working environment where it's frowned upon to acknowledge that you are struggling or that you don't know what you're doing, that is not very helpful for anybody, and it probably means that you have quite a toxic working environment. So that also helps. So educating yourself, and finding a community of people who you can open and honest and be vulnerable with and share that experience, that's really important. What didn't help was well, I suppose the way that I did it didn't help. Um, I mean, not having the formal qualifications, that just puts you on the back foot. Having to just fight to survive every day, and like those are things that just, it doesn't set you up for success, and it increases your stress. And we all have enough things to deal with in life. Your job is your job. I think we spent a lot of time doing what we did because we enjoyed it so much. But as you mature in your profession, you also realize that you need to have boundaries, and that's things that you develop over time. So not having boundaries doesn't help. Yeah, so I'd say probably the two most helpful things is having the formal qualification and finding a community of people who you can surround yourself with.
I think it's also really important just to remember, the same as when we're training to be clinicians, is that on the other end of sort of, and I want to speak from my own experience, on the other end of my terrible ability to teach in those first 2 years is a student who is at a disadvantage because I was not as good as I should have been. And then really I only started learning how to teach and be better at teaching 2 or 3 years into my teaching career. So those first 2 years of formal teaching, I don't know how those students coped, because they were not just dealing with difficult content and difficult situations, but also an inept instructor. So it's a miracle that they passed in my mind. I see Cindy's hand is up. Shall we go to Cindy?
Hi, Caleb. Thanks very much. I know I often chip in these conversations, but hopefully I can just make people think. So I'm an imposter, but telling the truth and saying I don't know was to my benefit. So I was on the first ever NDIP course back in 1987, and did my BTEC in 2000, and came off the road in 2000, and started to work in the hospital environment, first as safety and then as a transplant coordinator, which I've been doing ever since. And during that time, I doubled up for 9 years as a unit manager of the emergency department. I managed to get the opportunity because it was a new hospital and they were trying to save some money, and transplant was quiet because I do heart and lungs, and was able to step into that role and fulfill a dual purpose. Interestingly enough, managing nurses The one way that builds trust and won them over was not being scared to say, I don't know. Sharing that I know the emergency stuff, you know the nurse stuff, let's teach each other. And by saying I don't know, they knew that I would say if I was out of my depth. And it built that trust in them to say, I don't know. And it was, come here, let's show you. If somebody says, I don't know, and tries to fudge it along and makes a hash of it, you're a bit reluctant to then ask them again, because they won't say if they actually don't know how to do it. So I found with being an imposter, and still to this day, I'm called Sister Goldie, and I always joke about it that I'm an honorary nurse, because it's just too hard to explain otherwise. I still involved in clinical because I do donor management in the ICU, and a lot of that is fake it till you make it, because not being at the bedside 24, right? We don't have enough donor referrals, so sadly we don't get to do it every day. But thankfully we're working on deceased people, so that lets us off the hook a little bit. And sometimes we have to manipulate it to get it right. But changing from within your own area of expertise to now a completely new realm, it's very scary, and also worth it.
Awesome. Thanks, Cindy.
I want to just
go ahead.
Oh,
Judy.
sorry. No, I just wanted to hop on there. Thanks for sharing that, Cindy. And you mentioned that you were kind of in two roles at the same time. And my work obviously focuses a lot on the professional identity. And you can have what they call a blended identity, and this is often what people experience when they transition from one area into the next, where they're not fully willing to let go of the one identity entirely. So they have this very strong clinical identity, and they're not really wanting to or able to let that go because they feel so confident in that identity. So it does take time to develop the confidence throughout that imposter period, developing the confidence before you can fully adopt that new identity. If you want to, a lot of people will be in education for 10, 15 years, and they still identify more strongly with the clinical environment than the academic environment. And a part of the next part of my research that I'm doing is looking a little bit deeper into that, because there's evidence that says how you identify translates into the quality of the work that you do. So if you have this very strong clinical identity, how does that translate to you being in education? But that's just a little bit onto more of my work. There was another thing I wanted to say on what you mentioned, Cindy, about being honest about saying that you don't know. And I think in the education space, or if you're a manager, I think that has to do with how you conduct yourself. So I have worked with people who would just absolutely refuse to acknowledge that they have been wrong or that they don't know. And I just quickly scrolled through the chat to see who is online, and there are some of my previous students who are online, and it'll be great to hear their input on this. But I try to always create an environment where it is okay to say that you don't know, and it is okay to say that that you feel uncomfortable in this environment. And I think that creates a safe space where people are willing to acknowledge if they are struggling or if they don't know. And the same way that I would want students or future clinicians to acknowledge their limitation, because at the end of a student who turns into a graduate is a patient who's going to be treated. And if I cannot cultivate this idea that it is okay to say if you don't know, and it is okay to ask for advice, then they are going to feel like they need to make a decision even if they don't actually know what the correct thing is, and that could be detrimental to a patient. So I think, as you also mentioned, Cindy, cultivating that environment where it is okay to acknowledge your limitation. It is okay to apologize. It is okay to say that you don't know. That really creates an environment where people are willing to share their vulnerability. And I think that does create a better environment to learn. And that ultimately creates a student and a graduate and a future practitioner who will be safe, who will acknowledge if they don't know, and who can go, you know what, I am out of my depth here and I need help.
Absolutely. And it definitely is an opportunity to learn new skills and grow.
Judy, please help me to remember. I want to come back to this concept of mentorship, because I think we've segued into it really nicely. But I see Debbie does have her hand up as well.
Hi, Judy. It's
Hello.
so good to hear more about your research. I had some thoughts while I was listening to you a little bit earlier, and also to bring a bit of maybe just some thoughts that you could answer with some challenges that I've been facing. So I really enjoyed the way you just said now blended. You used the word blended because that's the environment I'm in, and I'm going to double blend. I actually ended up recently moving into an educator role out of MS. So I've had to move away from the sort of the life I know of medicine and move into business, which was quite a dynamic challenge in the blending, if that makes sense. But to go back to medical per se, I find one of my personal challenges is the expectation from society. And I'll explain to you and say that, so I still work clinically, but the clinical I work is more in the aviation environment. So it's more the high acuity type patients that we see. And because I'm also an educator in emergency medicine, I'm found that the expectation of my clinical work is always there, and I'm always expected to be able to know the answers and to be able to assist. And because my education per se is, let's say I do 90% of my work as my business, and say 10% time in clinical, sometimes my society's expectations and my personal reality are two different worlds. And yes, we're set up for success, and having someone to fall back in, someone to phone and say, please, help me, I'm a bit stuck here. But other than educating myself and going to lots of practicing environments, it's my responsibility to keep up. And I find that that expectation of my title quite a weight on my shoulders on some days, especially when I'm faced with quite a challenging patient. The second thing is also the move from past to present, and I think you and maybe Caleb will actually feel it as well, is previously we were just dumped out of a clinical role into education to fill a gap. And we winged it. We really, really did. I really feel for some of the students that we put through and how they managed to grapple with the education that we didn't know a thing about. But today we are expected to step up to the plate and talk the language of education. And leaving our environments, unless you're in an educator role, it's very difficult to go and learn education in order to become or to move into that environment, with part-time learning and that sort of thing. So those were just two of the sort of thoughts that I had, is the expectation based on your title. And that's why sometimes I actually just, I choose my title carefully depending on the environment I'm in, just to negate that expectation.
Yeah, that choosing the title, that's something that has come out in some of the not yet completed research that I have done as well, having lots of chats with people in the profession, where they do say that they will change how they refer to themselves based on who the audience is. And that's maybe an easy out for you. So it might not necessarily be how you identify professionally, but it's, as you say, it's just to negate having to defend your title and defend who you are in that space. I wanted to just chat about the feeling like you need to know everything because you work in education. I think Caleb and I both had this experience working on the Tango vehicle at the Netcare College back then, where when we would arrive on scene, then immediately everyone is nervous and people are like, oh no, the Tango vehicle is coming. And people were scared of having us on scene. And that was, Caleb and I we're just two humans, two other practitioners arriving because we have students who need some experience to treat patients, or we are just honestly there because we are there for backup and we want to have some clinical interactions as well. And no, we don't know everything. I still don't know everything. And I'm quite happy to acknowledge when I don't know something. But I think if you're early on in your career, especially in the EMS, where it's just, no, you can't say if you don't know something. You just go quietly and find out the answer instead of saying that you don't know. And I think that stems from how we were maybe treated 20 years ago in the profession, where if you're a volunteer or you are a student and you go and work with somebody and God forbid you don't know the answer, you would be scolded and ostracized and not allowed into the ambulance base because you didn't know the contraindication to one of the medication. And that is an unrealistic expectation to put on somebody. No one should be made to feel or belittled because they didn't know something. At any point in our career, we are going to be faced with something that we do not know what to do. So it's really great that the profession is moving towards it's okay to use a reference card. It is okay to use an app to look up something because we are humans. We are not computers. We cannot remember everything and recite everything. So I share that sentiment of the expectation that you know everything just because you work in education. So I'm sorry to disappoint everyone who thinks that the people who work in education know everything. If they tell you that they know everything, they are lying. And then the other thing that you spoke about was the expectation of higher education at the moment in the profession. So we all know that 2018, the short courses were officially came to an end and all the institutions were required to transition to formal higher education. And with higher education comes different expectations. You move away from that very skills orientated training towards the more critical thinking, evidence-based practice, research, academic style of education. And that is a massive transition. So people who were working in education throughout that time, you might have been trained via the short courses and you've been working at the ambulance training college for many years, and now suddenly you're a higher education institution and now you have all these additional expectations. So that is another hard transition that I think everyone in South Africa's paramedic education realm kind of went through a couple of years ago. I remember, Caleb, you and I and a couple of others, we were involved with the starting to include the ECA and the ECT qualifications back then, and it was hard. We were sitting in these meetings and they were using words and saying things that we just nodded, but I had no idea what they were talking about.
Definitely. Yeah, I think there's so much to unpack in these conversations. I do want to give everyone whose hands up a chance. So I think let's go Richard, and then we'll get Judy's thoughts on what you have to say.
Yeah, very good morning, Caleb and Judy. Thanks, Judy, for a very interesting talk. Just a quick question. When you went over to the States and to Australia and you practiced as an ECP, did you have to do bridging courses or was our qualification recognized over there?
So our qualification, if it's a university-based qualification, it is accepted here. So you do need to go through a registration process to obtain registration with their equivalent of the HPCSA. But the qualifications, if they are university-based, they are accepted. You do have a change in your scope of practice because obviously it needs to align with how they work here. the university level qualifications are accepted.
Awesome. Thanks, Judy and Richard. Louis, your hand has been up for a while.
Yeah, thanks. Thanks, Judy. I jumped in really late, so the comment or the question, it's not a question, it's more a comment, might have been touched on already. And I think Debbie kind of alluded to it to an extent. I think, and this is personally reflecting on my own career as well, we often change seats within an organization or within the profession, but and as rightly so, as Debbie said, you are still seen as the paramedic or the clinician that used to practice in whichever environment. And I think to kind of come to bits with it and make that decision that, hey, I've transitioned now into and I'm speaking about myself, into a management capacity where it's a lot more paperwork, sitting behind a computer, not having the lights and sirens and not having a patient in front of me. But internally, I still reflect as, hey, you are the good clinician that's clinically up to date, that's trying to read, that's trying to stay in touch with what's happening in the reality. I think it becomes even more awkward as you venture into the academia space. And now you're sitting, and again, like I said, I'm personally reflecting on myself. You're sitting in a management capacity with influence in the academic space, and you are still expected to deliver equally well on master's students that you're supervising or PhD students that you're supervising. But when you go out and you go out into the fraternity of EMS, people still look at you as, hey, Louis, the clinician that needs to have the answers. And I think what I want to come into as it's not a conclusion, but it is, we need to realize as individuals that it's okay once we change our hats or our seats within organizations, that our primary responsibility is not just to run with the red lights and sirens anymore. You've got a different role, and we need to fulfill that role in that space, not negating the importance of where you've started and what you mean to the greater EMS society, or to your organization, or to the people that follow you by designation, or just naturally kind of negate to follow the things that you do in the profession. And if I do recall, and I think, Judy, we might have had this conversation before, but there's, and it's something that came out of the UK space specifically, where they have a lot of academics that's sitting within the ambulance services, so within operations or within industry. And yes, they're actually looking at it from a research perspective. They're trying to bring in evidence-based kind of things. Yeah. But similarly, if we look across the board to our emergency medicine colleagues, that some of them are still practicing at the bedside, but you find them being a professor or whatever by academic designation. Can Ayanda please be muted? Sorry, so you find them in the EM space, and they are actually academics by trade. And if you speak to many of them, they would actually tell you it's okay to not be that top-notch clinician anymore, even though you're still patient-facing, but your role has changed. And I think it's not for me to say that, hey, let's negate the clinical responsibility we have. All I'm saying is you need to own the role that you're currently sitting in. And if that is a clinical space, then of course it is that I need to be top-notch clinically and awake. But I might be an educator, which has a different role, and I need to facilitate that knowledge transitioning. Or I might be sitting in a management space, but I have influence in the others. But I'm starting to speak over myself, and that happens quite often. So I'm going to stop there. But I just kind of I wanted to say that we need to own the space that we're in, not negating where we came from, but also, importantly, own the hat that you are currently wearing, and don't just kind of shove it away. Thanks, Judy. Sorry, I got carried away, as usual.
No, that's fine. Thanks, Louis. And I think you touch on something that's very, very important there. And that is all of these hats that you can wear, clinical, leadership, management, education, they are all mutually equal. They are all needed. We need people in all of those spaces. What would happen with emergency services if everyone wants to just be the clinician, if nobody wants to be the manager, if nobody wants to teach? It's going to go belly up. It's not going to be a good thing. So the one part or one of those hats is not superior or inferior to the other. We need to have people in all of those, and it is okay to be in more than one of those spaces at any given time. Maybe it just takes you a bit of a longer time to identify where it is that you see yourself. Like Caleb and I and some of our other colleagues who worked with us, we worked in both the clinical and the education spaces together for a while. And I think that was really good. But for me, certainly, and it's not the same for Caleb, I have not treated a patient since 2017. I still have an ECP qualification, but if they are going to ask for somebody to put their hand up who wants to go and do an ICU transfer, I'm definitely not putting my hand up. And I'm quite okay to admit that. 10 years ago, I was great at doing ICU transfers. I was doing them all the time. I was super confident in doing them. Now I have not done that in many years. So will I be able to do it? Sure. Am I going to be the best practitioner doing that ICU transfer? Absolutely not. Somebody who is much less years qualified than I am is going to be better at doing that because they are more current in that space. But my role is equally as important because being a researcher and being an educator, we are paving the way and coming in and coming up with new things to improve the profession and to pave the way for the next generation. I'm not going to be around forever. So I need to try, if I want the profession to continue, then we need to make sure that we are educating the next generation of clinicians to want to become leaders and managers and educators. So yeah, that's a very important point that you made, Louis, with there's multiple hats and you can wear multiple of them, and you need to own the space that you are in each of those because they are all equally as important.
And I think what's really important is that you actually can't wear all the hats. Something has to give, and at some point you have to pick maybe one or two of the hats that you're keen to wear, but you can't wear them all. I want to go to Tash. I think she's got a really good question that sort of backs onto what you've just said now around how you figure out where you fit. But what I want to just throw in before Tash jumps in is maybe just the thought about when you are saying, I am no longer the right person for that critical care transfer or that primary case, how much guilt or shame goes with it until you are really embracing that role? So we'll go to Tash and then maybe think about those things.
Okay.
So my question is also really a personal one, and it ties into everything that you've said. So it's pointed at whether your research has indicated anything about grieving the clinical identity. For me, it's been almost 2 years now that I haven't been clinical, and having transitioned from clinical to education to business management, it leaves a really profound and sad and empty feeling for me. There's several reasons, personal and professional, that has brought my clinical journey to an end. But it doesn't matter how much I embed myself into education and businesswoman profile, it's still this massive gap, and it automatically makes me feel less in certain audiences. So my question is there any evidence that indicate that hanging on to the loss of the clinical identity equates to not fully embodying yourself into the other identities?
100%. Yes, there is. And there's a lot of people who share that sentiment. So you are absolutely not alone in feeling like that. There's nothing wrong with you because you feel like that. And I think the most important bit that you've mentioned is that the reasons why your clinical career came to an end both personal and professional reasons why, and that is unique to you. So when people say things like those who can't do teach, that is insulting, because you do not know why somebody has chosen to make a career change. Maybe they didn't make a decision to do career change. Maybe it is as a result of something else that they have been forced to make a career change. So absolutely, they are going to be grieving that however many years of career that they now have to leave behind, whether by choice or not. So yes, there is existing evidence, and I mean, I don't want to say too much about what is going to come out of the next part of my PhD, but because I spoke specifically to the South African EMS education and academic community. So they were the cohorts and the participants in my research, and that sentiment is shared. I have had similar feelings, I suppose, maybe not as strong, because even before I went into education, I always knew that I wasn't going to be clinical forever. While I enjoyed my clinical time very, very much, and I do believe that I was good at when I was a clinician, when I transitioned out of the clinical space, for me it was exciting because I knew it. I wanted to transition out of the clinical space. I wasn't entirely sure where I wanted to transition to. So me going into education and academia was kind of just a product of the circumstance at the time, but I'm very happy with that outcome. But in your case, Tash, where, I mean, whatever the reasons are that you are now in the businesswoman avenue, we don't know. And that is, so you are absolutely allowed to feel all the feelings that you are feeling, and it's normal. You're not alone, and the change in identity does come with grief and having to leave your prior identity behind.
Yeah, awesome. Yeah, and there's so much there that we could speak for hours about. I want to pop over to Gilbert. Sorry, Judy.
No. We can take Gilbert's question, and then there's some questions in the chat also that that I can speak to.
Amazing, Gilbert.
Hi, thank you, Teres, and thank you, Gideon. Well done on your PhD. I wanted to ask quickly, firstly, on this question
My
that
volume
we are talking about.
offset.
Can you hear me?
Yes, I can.
Yeah, okay, thank you. Yes, on this question, maybe it was part of your research on your PhD. As where is perception stays in EMS that if you are in the teaching space, you should still remain in the clinical space? Because when we look at medicine and nursing, nurses don't, once they go into education, they don't still go to the wards and treat patients to remain clinical. Even doctors, professors, they don't do that. But somehow in the EMS, there's still some perception that you must still be treating patients and teaching at the same time to remain current. Maybe you've done something on that to see where the perceptions come from. And then the second one was, you know, when somebody may be coming into the teaching space, you know, in EMS, we know we're very clear on what is a AEA, we're very clear on what is a ECP or ANT. But in education, you know, these terminologies are so many. And at the end of the day, it's somebody standing in front of the class or students and giving information in terms of whether you are a lecturer or you are a trainer, you are an instructor, you are a facilitator. So all of these terms, for example, I would say I'm a BLS instructor. And if I look at what an instructor do and what you're doing as a BLS instructor, it feels more like I'm a facilitator and I'm not an instructor. So are there, you know, how does a person maybe place themselves to say, no, I'm not an instructor, I'm a facilitator. I'm not a facilitator, I'm a lecturer. I'm not a lecturer, I'm a trainer, in those things.
Thank you for those questions, Gilbert. Those are awesome questions. So I'm going to start with the first one about the remaining clinically current. And that is a perception that is very much unique. I don't want to say unique, but it's very prevalent in emergency medicine. And Louis touched on this as well a little bit earlier. And some areas are able to manage the two of them overlapping a little bit better than I think we are currently doing that in the EMS. And in the the research that I was doing, there's no question or there's no doubt about the benefit that having clinical experience brings to being an educator or an instructor. So there's a lot of people who agree or who seem to think, or their perception is that in order to be effective as an educator in something clinical, you should have experience. Whether you agree with that or not, that is something else. And in my future publications, maybe I can clarify that a little bit more, but there does remain a lot of confusion about it. And I think a lot of that stems from the students' perception, because students often feel that if the person standing in front of them doesn't have street cred, then why should I listen to anything that you have to say? But then, as Tash mentioned, you don't know why that person has decided to move out of the clinical space and into a different space. So it's not a fair judgment to put onto someone. And if that person is standing in front of you as the instructor, the facilitator, the lecturer, or the professor, they are not going to be put there if they don't have some credibility to be in that position. So there's a lot of work that can be done to change the culture and change the perception that you can only be good at education if you still treat patients. I'm very passionate about education, and I am very proud to say that I like to do innovative things in education, and I'm publishing research, and I'm an active contributor in the academic space, but I haven't treated a patient since 2017. So it's also about how you conduct yourself, and that again relates back to your confidence and the space that you're in and the space that you create, about being open and being vulnerable and being able to share that, listen, I haven't treated patients in a very long time, but I am still allowed to be in the position as your lecturer or your educator. And then the next one on the terminology, and that is something that this current publication of mine that is out is wanting to highlight, is this inconsistency. And you've mentioned yourself, Gilbert, that even though you are termed BLS instructor, you feel more like a facilitator. An instructor is very militaristic, like stands in front of the class and gives orders. And I don't think that that is what you do as the person who facilitates a BLS course. So rightly so, your feeling of, I feel more like a facilitator than an instructor, that is absolutely warranted. And that is what I'm trying to bring across with this research, is that there is this inconsistency, and this inconsistency has an effect on how people conduct themselves. So thank you for highlighting that.
Judy, I don't
Anything
know if you want to attack some of those questions in the chat.
Yes. Are you staying on, or do you have to go?
I'm going to be driving now, but
Oh,
super happy
okay.
to stay on. Yeah.
Okay, I'm just going to go from the top of the chat for now, and then I'll take some more questions if we have some more time. So not all the comments have names attached to them. If you're not talking, can you please just put yourself on mute? Thank you. So there's a comment about people who take students and have students working with them. That is also a form of teaching and knowledge sharing, and that's absolutely true. It's just, and that's why in undergraduate studies you do get exposed to how to be a good mentor and how to be able to facilitate. Oh gosh, the echo.
Guys, sorry, if you are not Judy, please mute yourself. We can hear your whole conversation.
Thank you. Where we are now. Oh gosh, let me go back to that question. So being a mentor and informal learning. So there's different types of learning. So 100%, if you are facilitating students working with you, then you are participating in form of informal learning, and that's great. The next comment is about if an instructor tells you not to try something again, and that's something that I think people who are standing in the front of the classroom, they don't often realize how much impact they have on the people sitting in front of them. I've had a couple of people talk to me about experience that they had when they were students, and how one simple comment has that the lecturer or the instructor might have not even really thought about when they made the comment has had such a profound impact on that person's career trajectory. So I can absolutely resonate with the educator or the person who's meant to be your mentor that says things like, you absolutely shouldn't try that again. But actually having an understanding of what your responsibility is if you are taking on the role of anything in education. What would the suggested route be to follow if you wanted to start focusing on education and not so much clinical? Was a postgrad in education, a PGDip in education satisfactory? So absolutely. So there's quite a few shorter postgrad qualifications that you can do specific to adult education, higher education, or more specifically health professions education. So any of those is a good starting point. They all kind of cover things like the educational theories and what is curriculum design, what is teaching and learning, what is assessment, and that's kind of really the basics that you need to cover if you want to be effective in your role as an educator. On an international forum, so every country has their own version of a postgraduate diploma or a postgraduate certificate, but they do cover similar levels of knowledge with regards to higher education. It's not always just immediately accepted if you've obtained a qualification in one country and then you want to go and apply it in another country, because every country has its own contextual factors that you would need to consider. But for the most part, I've been able to be accepted in the academic spaces with both of my education qualifications being from South Africa. I really like this next one where, do you think universities train their graduates to be bullies, particularly in the EMS? And I've not worked in education in South Africa for a couple of years. So I left in 2017 and then I came back for 3 years, and then I came to Australia. But prior to 2017, I would say not all of them do, but a lot of the culture in EMS education is militaristic, and while it doesn't necessarily maybe train them to be bullies, that is the behavior that is modeled. And it comes back again to what is the responsibility of educators. And if you are not critically aware of what your responsibility is as an educator, you are going to teach how you were taught. And that's pretty much what I did in those early years. So yes, I think there's a lot that can be done to change the culture of EMS training in South Africa. And I'm just going to leave it at that. If you've been exposed to bullying, then you're likely to be a bully. So yes, if you are, if that's the behavior that you're used to being exposed to, then that is what is modeled, and you look up to the people who teach you and you think that they are the be all and end all. And then if you've been around for a couple of years, then you realize that actually they are not the be all and end all, but that is how they conduct themselves, which is not always the right way. I do feel for the people who have short course education and training and the pathways that do not exist fully for them to transition into formal higher education. And yes, I think if we start that conversation, we're going to be here for another 2 hours. I agree that the way that process was gone about and how the short courses were, it wasn't even phased out, it was just stopped. And then now this is the only option. And I don't think that it's too late to be able to develop something that does give people opportunity in order to transition into formal higher education. And Debbie, who spoke earlier, I know she's done a lot of work on the people who are vocationally trained transitioning into higher education. So it's not too late, and I think that change can still be made. It's just about getting everyone to have the same feeling towards that. Okay, lots of people agreeing with the better pathway for transition that is needed to happen. Oh, the comments are going backwards and forward. There's someone who asked for my email to be shared. I will be more than happy to share my email. And then Louis made a comment where we just need to make sure that we are having the conversations with the right people about enabling these additional pathways or future pathways for the vocationally trained clinicians in order to transition to higher education. Oh gosh, every time I try and read a comment, it just goes backwards and forwards. If there's anyone else who has a comment, feel free to put up your hand. I'm trying to get through the comments.
Judy?
Yes.
If I may, I just want to add on that comment that I made regarding speaking to the right kind of role players and things. And I think that's something that, and I might get wrapped across the knuckles for what I'm going to say, but I think it needs to be said. As much as I made that comment that the HPCSA does not set the educational pathways. There is set standards for curriculums that needs to be followed through them, but that only refers to the accreditation process to say that a course meets its requirements. How that course gets delivered is entirely up to the higher education institutions. And I think Debbie has done some fundamental work in that space, and I know they've applied for, and I'm not going to say which specific course, but for some specific courses to be distance-based learning and those kind of things. And rightfully so saying that has been shot down by the HPCSA at that stage. But saying that there's an institution now that is going to go that route and run it through a distance learning module and have students coming in on whenever it's convenient for them to actually do that. So it won't be a bum in the seat module for education. The concern is that it gets allowed for certain individuals to do something in one way, and for the others you get told, no, it needs to be done another way. So yes, there's definitely some work that needs to be done in that space with regards to standardized RPL, standardized alternative access pathways. But a big ball sits with the actual higher education institution, whichever one they are, whichever ones we refer to. I think, and this is something that we can't shunt away from, there is financial incentive for universities to have bum in the seat courses rather than running distance-based education where someone is not on campus and not making use of campus facilities. And I think we shouldn't shy away from that conversation. And me not saying this because of being involved with EXA, but EXA has had its up and downs, but that is one society that should advocate for alternative pathways, and what are those, and how do we actually echo those out to higher education institutions? Because if the profession makes the noise, which it has been making, but it's been making the noise at at the HPCSA. And as much as they have currently power to say yes or no, that's not the correct door. And that's all I want to add on there. Thanks, Judy.
No worries. Thank you for adding that bit, Louis. So there's a couple of questions or comments that I want to maybe address at once. And the person who wrote about, it seems like the ECP qualification is everything. I'm really sorry that you feel like that. And as someone who has an ECP qualification that I no longer use, I've often offered to give it away because I don't really need it anymore. Because my identity has very much changed. I'm not trying to make light of the frustration that you do have, and you are absolutely not the only person who feels like this. And that again is a cultural thing that has been bred in the EMS in South Africa. By some institutions, maybe more than others, where the ECP is the be all and end all, and it is not. The same way that you need clinicians and educators and managers, you also need people who can serve the community. So you mentioned that you have an ANT qualification and you have loads of other postgrad qualifications, but it still doesn't seem like enough because on the HPCSA register, you do not have an ECP number. What is being done about that at the moment? It's hard to change culture and to get out of the bureaucracy. And I don't think that a change is going to happen in a short space of time. But the more of us that have conversation about this and who speak to the fact that everyone has something to give, and irrespective of what you are at the HPCSA and what your number is on the roll, you have other qualifications and you have other things to offer. And I think that that is just a massive cultural shift that needs to take place in the EMS. And that kind of links to some of the other questions, which is about RPL. RPL it's got the same meaning at every institution, but every institution has their own little rules about it, what it can be used for and what it can't be used for. I used to be on an RPL committee at an EMS university in South Africa, and it was really frustrating being on that committee because people would be applying to study at the university, and I had no doubt that they would be amazing practitioners at whatever level, but because of the university's rules, they weren't allowed that. And I think that is unfair. So there's also a lot of work that can be done with recognition of prior learning. And again, there are people that is doing work in these spaces. It's just unfortunate that research, to see the outcomes and the effects of research, it takes time. Caleb, there's a couple of people who have to log off. So what is the word of the day? Can we make it identity?
Yeah, that's perfect. Word of the day is
okay.
identity, and I'll post the link in a sec.
Thank you. Okay, there's one other question. I share the frustration of the person who has an ILS qualification, and that is something that RPL should consider. Is if you have an ILS qualification, and you might have been having an ILS qualification for the last 10 or 15 years, and you are what they would call a mature student, so you haven't just left school, which means that you have other responsibilities than somebody who has just left school. And often higher education in South Africa overlooks that. That's something that I have experienced in other parts of the world, having worked in the UK and now in Australia. We do that a bit better in Australia and the UK, where mature students are better integrated into higher education, the ones who have carer responsibilities and who have jobs, etc. So absolutely, South Africa can do a lot more to support in that space. Are there any other questions? I don't know how to see if anyone has their hand up. Louis, it looks like you still have your hand up. Oh, no, it's not.
If it was legendary, but no, it's not there.
If there's no more,
two people
yeah,
on the same computer, so it's not Anthony, it's Almarie. But I just wanted to make a comment about the ECP being all and end all. I definitely agree it is not the be all and end all. And I think that also that culture plays into the ECP burnout. I've met amazing A&T paramedics and ILSs and BLSs that have allowed me to be less burnt out. And I think that also goes into the education perspective of it, where, you know, even an ILS can mentor me on certain things, that because everybody has different skills and our specialities at different stuff. Yeah, and I think it's a team thing. So if we like kind of more come together with that, and the ECP is not the be all and end all, it's definitely a team effort, and mentorship goes both ways. Yeah, I think that would be really cool.
Yeah, thank you for that. That's really important. I've learned loads of things from people who are lower qualified.